Hi learners, it's Em from Sononerds, and this video is going to be on Unit 7, where we are going to cover the peritoneal cavity, retroperitoneum, and the abdominal wall. The retroperitoneum and the peritoneum are cavities in the body that are distinguishable by the peritoneal lining. The peritoneal cavity was covered previously in Unit 2 in abdominal cavities. The abdominal wall is the skin and muscles that surround the torso. So in Unit 7, we are going to review the peritoneal cavity, look more at the anatomy of the retroperitoneal cavity, and lastly cover the anatomy of the abdominal wall. This unit will provide some brief discussion on organ anatomy like the kidney, spleen, aorta, IVC, and lymph nodes. However, more detailed anatomy lectures will be covered in those dedicated units. Now, the adrenal glands will be discussed in a little bit more detail anatomically, but the physiology portion will be left for the pathology lecture, as most adrenal pathology has to do with its physiology. Physiology of the cavities and the abdominal wall otherwise is pretty minimal. The ultrasound image review of these structures will be mainly to point out structures that you may see during an abdominal imaging study. There aren't a whole lot of exams that can be ordered that would be dedicated to a cavity per se, but because it's ultrasound, it's not uncommon to go with the old, well, let's see what we see. So, being able to recognize some superficial structures and landmarks within the body will be helpful. Since the cavities and abdominal wall are not clearly defined organ systems, the last section will cover some uses of ultrasound as it pertains to structures covered in this unit. Section 7.1, Peritoneal Cavity. Recall that the peritoneum is the lining of the peritoneal cavity, and it has two layers. The visceral layer, which covers the peritoneal organs, and the parietal layer, which covers the abdominal wall. Within the peritoneal cavity, the peritoneum folds on itself, creating ligaments and potential spaces. While there are no organs physically inside the peritoneum, there are organs that are enveloped by the peritoneum covering that are considered intraperitoneal organs. Where the peritoneum completely covers an organ, a suspensory ligament forms to anchor the organ to the abdominal wall. This is the case with the mesentery that supports the small intestine, as well as the transverse colon, the sigmoid colon, the liver, and so on. So the peritoneal organs include the liver, gallbladder, spleen, stomach, ovaries and uterus, parts of the pancreas, parts of the duodenum, the ileum, jejunum, and parts of the colon and rectum. So the way I like to remember peritoneal cavity organs is to think of GLOS. So we have the gallbladder, liver, ovaries and uterus, the stomach, and the spleen, plus the small bowel and other parts of the colon. For the sonographer, the major implication of the peritoneal cavity is to identify the cavity from which fluid or mass is arising. Location of the fluid or the mass changes the patient's care. Knowing that the diaphragm is the division between the pleural cavity and the abdominal cavity, identifying the diaphragm and locating fluid on either side of it is going to be helpful to determine pleural versus subdiaphragmatic fluid. When we see fluid in that subdiaphragmatic position in the peritoneum, that is called ascites. When there's fluid above the diaphragm in the pleural cavity or in the thoracic cavity, that is called an effusion. So in this image here, we can see the diaphragm coming across. Any fluid that is above the diaphragm around the lungs is considered a pleural effusion, where any fluid that resides anywhere within the peritoneal cavity is ascites. Note that there is one special area in the peritoneum in which the liver is in direct contact with the diaphragm, and this makes the bare area, and no fluid can collect in this area. Another delineation needs to occur between intraperitoneal fluid and subcapsular fluid. The liver and spleen are both covered by a fibrous capsule and are both highly susceptible to trauma and bleeding. The sonographer needs to determine if fluid is seen outside of the capsule and in the peritoneum or under the capsule being confined to the organ. In this image here, we can see a patient who was recently in a car accident exhibiting the seat belt sign, and that probably is relatively obvious with the strap coming here and the bruises across here. We can see that the patient has bruising over the right upper quadrant and the left upper quadrant. This patient might have some sort of intra-abdominal bleeding. We would want to know, is it within the peritoneum or is it being confined to the organ itself, being held in by the capsule of the organ? And lastly, retroperitoneal masses tend to push anatomy more anteriorly or towards the head cranially. This means that if we see anteriorly displaced great vessels or other abdominal vasculature, the mass is most likely retroperitoneal in origin. If the mass appears to move with the liver or pushes vessels more posterior, then the mass is more likely intraperitoneal. So in this image here, we have the kidneys, which are retroperitoneal organs, and this extra stuff is kind of representing a mass building up within the retroperitoneum. And we can see that it is moving structures that are in the peritoneum a little bit more anterior, moving them away from the retroperitoneum. So again, masses that arise from the retroperitoneum are going to push the anatomy towards the anterior or possibly towards the head, where masses that arise from the peritoneum are going to push the retroperitoneal organs back towards the patient's dorsal side. Section 7.2, Retroperitoneum. The retroperitoneum sits behind the peritoneum, but in front of the posterior abdominal wall. Its location is surrounded by spine, ribs, fat, and musculature, which makes it slightly difficult to assess the space itself by ultrasound, but the organs within the retroperitoneum can be seen very well. The organs within the retroperitoneal space may have some visceral peritoneum covering them, but because they are not completely covered by peritoneum, they are not considered intraperitoneal organs. So the retroperitoneal organs are going to include the suprarenal, which are also known as adrenal glands, the aorta and IVC, the duodenum, pancreas, ureters, colon, kidneys, esophagus, and the rectum. I want to point out that some of this anatomy does mention that it's part of the anatomy being within the retroperitoneum. That means the other part of it is within the peritoneum. To avoid confusion, most of the organs listed in the retroperitoneum here with the parts of reside mostly within the retroperitoneum. So these parts of, there's just a couple parts of the duodenum that sit in the peritoneum. It's the pancreas head that sits in the peritoneum. Most of the body sits in the retroperitoneum. The sigmoid colon is part of the peritoneum, but most of it sits in the retroperitoneum. Same with the rectum. The superior portion of the rectum does sit in the peritoneum, but most of it sits in the retroperitoneum. So this list of retroperitoneal organs is all-inclusive. I would remember these organs versus knowing that there are parts of these organs that lie within the peritoneum. So classify them as retroperitoneum versus peritoneum. To remember these organs, then, we can use our mnemonic device of Sadpucker. So using the Sadpucker mnemonic device tells us the beginning letter of each of the organs that is found within the retroperitoneum. The retroperitoneum is divided into three main spaces. We have the anterior pararenal space, the perirenal space, and the posterior pararenal space. Now in the anterior pararenal space, this is going to be right between the peritoneum and the perirenal area. We can see that it includes the colon, ascending and descending, and it also includes most of the pancreas. The perirenal space is going to include both kidneys, ureters, adrenal glands, and the great vessels. So we can see it's the area that surrounds the kidneys, hence the perirenal next to the kidneys. The purple area then is the posterior pararenal, and there aren't really any organs found in the posterior pararenal space, but it is an area that fluid can collect and lymph nodes can appear. There are some other spaces in the retroperitoneum that are going to be defined more by musculature of the abdominal wall. For example, we have the iliac fossa. Now this is known as the false pelvis. Organs in the iliac fossa are going to include the ureter, major branches of the distal vessels, so the IVC and aorta branches, and some lymphatic vessels. We also have the retrofacial space, which is the area that's going to be home to the psoas muscle and the quadratus lumborum muscle. And then we also have the pelvic retroperitoneum, which has 4 subdivisions, including the prevesical and retrovesical spaces, presacral space, and bilateral pararectal spaces. Section 7.3, Special Anatomy of the Retroperitoneum. We are going to take a look at some of the anatomy in the peritoneum that won't be discussed in further detail in any other units. This is going to include the adrenal glands, para-aortic lymph nodes, and the diaphragmatic crura. The adrenal glands are located in the retroperitoneum, and they are also known as the suprarenal glands. Remember, they are the S from Sadpucker. The adrenal glands can be found sitting anterior, superior, and medial to the kidneys. So they are anterior, so they sit closer to the front of the person or towards the abdominal wall. They are superior, which means they sit on the kidneys like little hats. And then they lean a little bit more medial, so they are closer to the midline of the body. Adrenal glands are going to vary in shape and size. However, the right adrenal gland tends to take on more of a triangle appearance to it because of the way that it fits in between the liver and the right kidney. And the left adrenal gland is going to take more of a semi-lunar or moon shape because of the way it fits in between the spleen and the left kidney. Each gland is going to consist of a cortex and a medulla. The cortex is the outside portion and has 3 layers to it. The medulla then is the inner portion. Cortex is the outer part, and the medulla is the middle part, middle medulla. So inside part medulla, outer part is cortex, and that cortex has 3 layers to it. We are not going to spend time learning those layers quite yet. We'll talk about that a little bit more when we get into the physiology of the adrenal gland. Taking a look then at the vasculature of the adrenal glands, there are 3 arteries that supply them. They are all suprarenal arteries, and they are the superior, middle, and inferior suprarenal artery. The superior suprarenal artery arises from the inferior phrenic arteries, which are arteries that go to the diaphragm. The aorta gives rise to the middle suprarenal artery, and then the renal arteries give rise to the inferior suprarenal or adrenal artery. Looking at the veins that drain each of the adrenal glands, there is one vein that comes out of the hilum of the adrenal gland. On the right side, we'll see the right adrenal vein or the right suprarenal vein drain directly into the inferior vena cava, where the left adrenal vein or suprarenal vein is going to drain into the left renal vein, and then that is going to go to the IVC. Another special piece of anatomy in the retroperitoneum is the diaphragmatic crura. The diaphragmatic crura are fibrous sheaths that connect the lumbar vertebrae, specifically L3 on the right and L1 on the left, all the way back up to the diaphragm. They're a little tricky to see in the image here, but this cutout here, this is the diaphragm. Remember, it kind of wraps on the superior portion and then comes posterior behind the liver. And coming off the lumbar vertebrae is the right crus, which is going to connect from spine to diaphragm, and the left crus, which also connects from spine to diaphragm. The crus of the diaphragm refers to these tendinous structures that are going to extend again from the diaphragm to the vertebral column. The diaphragmatic crus give the diaphragm something to kind of pull against, to contract against, so it helps us with our breathing. And they are called diaphragmatic crus because they take on more of a leg shape, and crus happens to be Latin for leg. Lastly, we do have para-aortic lymph nodes. There are 2 major lymph node chains in the retroperitoneal cavity. The iliac and hypogastric nodes within the pelvis. So those are going to be the nodes that are more towards the iliac vessels here, down into the corners of the pelvis. And then we also have the para-aortic group, which is going to follow the main portion of the aorta through the retroperitoneum. Once the aorta pierces through the diaphragm, the lymph node chains do follow up through the thoracic aorta as well. Typically, normal lymph nodes within the abdomen are not appreciated by ultrasound. We usually don't see them until they get to be about 1 centimeter or bigger. The aorta and the inferior vena cava are both retroperitoneal and provide major arterial and venous branches to the other retroperitoneal organs as well as the peritoneal organs. They are going to be discussed in greater detail in the abdominal vasculature unit. Section 7.4, Abdominal Wall. The abdominal wall includes the muscle, fascia, fat, and skin that surrounds the abdominal cavity. Due to the nature of ultrasound, abdominal wall structures are usually seen in most of our abdominal imaging. The abdominal wall encloses the abdominal cavity and can be divided into the anterolateral and the posterior sections. The anterolateral abdominal wall consists of 4 main layers: the skin, superficial fascia, muscles, and the parietal peritoneum. The purpose of the abdominal wall is to provide a firm yet flexible boundary which keeps the abdominal viscera in the abdominal cavity and assists the viscera in maintaining their anatomical position against gravity. It's also going to protect the abdominal viscera from injury. It can also help in forceful expiration by kind of squeezing those abdominal viscera or the abdominal organs upwards. And then lastly, it is involved in any action like coughing or vomiting or defecation that increases the intra-abdominal pressure. And when we kind of flex our abdomen muscles to create that internal pressure that we have, like when we need a bowel movement or even like when we cough or vomit, that is called a Valsalva maneuver, by kind of creating that intra-abdominal pressure with the abdominal wall muscles. Focusing on the anterolateral muscles, those are going to be the muscles that are found on the front and the sides of the abdomen. There are 5 groups of muscles that layer upon themselves to create the muscular layer of the wall. From superficial to deep, we're going to cover each of them. The pyramidalis muscles are the most superficial muscle in the abdomen. They are going to be small triangular muscles that are found near the lower part of the abdomen, connecting to the pubis symphysis. So these 2 little muscles right here, these are the pyramidalis muscles. They are connected to the midline linea alba and to the pubis symphysis. Next, we have the external oblique muscles. These are going to be more to the side. They are still a very superficial flat muscle in the abdominal wall. And what's important about the external oblique is that we see the fibers of the muscle running inframedially. So that means that they are running down towards the patient's feet, but also angled towards the patient's midline. So inframedially. Next in, we have the rectus abdominis muscle. These are going to be located on the anterior portion of the abdominal wall. They are a long paired muscle found on either side of the midline. It is going to be split in 2 by the linea alba. So that's this line through the middle here. This is the linea alba. And then the lateral borders of the muscle on either side here create a surface marking known as the linea semilunaris. So this is often used as a landmark, dividing the abdomen into 9 regions. At several places within the abdominis rectus muscle, there are going to be these fiber strips that kind of intersect into it, and these are known as tendinous intersections. And between the linea albus and these tendinous intersections, this is where we get what we call the 6-pack in individuals that have very well-developed rectus abdominis muscles. Moving deeper into the body, then we have the internal oblique. These are going to be back onto the patient's side. The internal obliques are a little bit thinner, a little bit smaller than the external oblique, and these muscle fibers are going to run what we call supromedially. So that means that they have their insertion point towards the bottom here. They are going to extend superior towards the patient's head and medially towards the patient's midline. So they technically crisscross with the external oblique. So supromedially for the internal oblique, and the external oblique, remember they kind of ran inframedially, which would crisscross over the internal oblique. Lastly then, the deepest layer of muscles of the abdominal wall is called the transversus abdominis. Again, a set of flat muscles on either side of the abdomen. We are going to see the fibers of the transversus abdominis running across the stomach. So that follows with the transversus running across or transversing the abdomen. There is a fascial layer that sits in between each of these muscle layers, but underneath the transversus abdominis is a very well-defined, easy to see by ultrasound, and it's called the transversalis fascia. And it's a very thick one right before we get to the peritoneal lining. Now the posterior abdominal wall muscles are on the back part of our abdomen. Quadratus lumborum is the main posterior abdominal wall muscle, but the psoas muscle also supports the posterior abdomen and the lower limbs. Quadratus lumborum muscle is on the posterior side of the abdomen. It is going to sit deep and lateral to the spine, connecting the iliac crest to the spine and the ribs. So the quadratus lumborum is kind of this rectangular shaped muscle. Hence the quadratus, it has 4 sides to it. And the lumborum tells us that it connects to the lumbar vertebrae. So it's going to connect these iliac crests here back to the lumbar vertebrae. And this is going to form a really big chunk of our posterior abdominal musculature. The other muscle that we see in the area then is the psoas muscle. And the psoas muscle is going to connect to the spine down to the femur in the leg. So here we have the psoas muscle. It is actually pretty easily identified by ultrasound. We'll take a look at a couple pictures shortly here. But it is going to connect to the lumbar run through the retroperitoneum and the pelvis, connecting finally down into the leg. Up on top here, this is called the psoas major muscle. Eventually it will connect with the iliacus muscle to form the iliopsoas muscle more down into the pelvis. Some other structures that we can see involving the abdominal wall include the rectus sheath. The rectus sheath is formed by the aponeuroses of the three flat muscles. So the transverse, internal, and external oblique muscles all kind of have this like fascia that comes together. That's the aponeurosis. Those are all going to come together and form the rectus sheath. It's going to enclose the rectus abdominal muscles as well as the pyramidalis muscles. Another structure that we see on the abdominal wall is the umbilicus. The umbilicus is another name for the belly button, and it is probably the most visible structure on the abdominal wall. This is the location of umbilical cord attachment to a fetus, which served as the pathway for mother and baby to exchange nutrients and gases. And once that umbilical cord is disconnected, it does end up leaving a scar, which is our belly button. So we will see it usually located midway between the xiphoid process of the sternum and the pubis symphysis in the pelvis. Lastly, we've already mentioned it, but we have the linea alba. That is a strong fibrous band that sits very midline. We can see it as a visible groove that runs vertically from the xiphoid process inferiorly on the body. And lastly, just to again recall the 9 abdominal region that we talk about, now that we have discussed a little bit more organs and have talked a little bit more about the viscera within the abdominal cavity, again, we use the abdominal 9 division method to help describe location of pain, location of viscera, and to describe surgical procedures. So the 9 regions are going to be formed by 2 horizontal lines. We have one at the subcostal margin, and then we also have one at the intertubercular margin, which is part of the iliac crust here. The vertical lines then run down the semilunaris groove created by the abdominal rectus muscles, and that gives us our 9 regions. So we have the right hypochondriac region, epigastric region, and the left hypochondriac region on the top. Through the middle, we have the right lumbar region, umbilical region, and the left lumbar region. And then on the bottom, the right iliac region, hypogastric region, and the left iliac region. Section 7.5, ultrasound appearance. So let's take a look at some of these structures by ultrasound now. Remember, the goal is to recognize these structures as they appear in many of our abdominal ultrasound images. Beginning with the peritoneal cavity, I want to point out that the presence of fluid or blood product in the peritoneal cavity is not normal, but the presence of it can help us to identify those potential spaces that we've been talking about. In this first image here, we have an image of fluid within the subphrenic or subdiaphragmatic space. Remember, there are 2 subphrenic spaces, the right and the left, and they are going to sit just inferior to the diaphragm. Remember that the right and the left subdiaphragmatic spaces cannot communicate because of the bare area and the falciform ligament. So there will never be fluid in that bare area, which keeps the right and the left side very separate from one another. Looking at this image then, we want to always identify where the diaphragm is. That's going to be the first key thing. Identify the diaphragm, then you will know, is the fluid superior and in the pleural cavity, or is it inferior and in the peritoneal cavity? In this example, we have fluid inferior to the diaphragm. So this is subdiaphragmatic. It's a little hard to tell if this is for surely liver or spleen. Looks maybe a little bit more like the spleen. So this would be the left subphrenic space. We also have subhepatic spaces, so that's going to include a right anterior space, a right posterior space, and a left space. The right anterior space is going to be located between the right lobe of the liver and the right kidney, more into the anterior position, as the inferior pole of the right kidney comes up a little bit more anterior. The right posterior portion is also known as Morrison's pouch, and this is a very, very common space for fluid to appear. So the right posterior subhepatic space is on this posterior side. It's not uncommon just to see a little sliver of fluid in there, and if there's fluid in this area, then we want to make sure that we are going and looking around at the other quadrants, looking in the pelvis for more fluid. The left subhepatic space then is located over by the left lobe of the liver and is going to be near the stomach. We also have a space called the retropubic space. This is also known as the space of Rhesus. and this is going to be between the pubic bone and the urinary bladder. So when we are low in the pelvis, underneath the bladder, we're going to see this kind of shadowing area. That's the cartilage of the pubic bone or the pubis symphysis, and we might see some fluid in this area. So that is the space of rhesus. This is going to be more of a trauma related fluid collection. So if somebody has recently been in an accident, this is a good spot to look for a collection of fluid. We also have the lesser sac in the peritoneal cavity. Remember, the lesser sac is accessible through the epiploic foramen or the foramen of Winslow and is located between the stomach and the pancreas. And because of its location near the pancreas, this ends up being a very common space for what we call pseudocysts to form. The pseudocyst is a bunch of pancreatic enzymes that is kind of collected into one area due to pancreatitis. We also can find fluid in the pericolic gutters. There are two gutters, one that runs along the ascending, which is on the right side, and one that runs along the descending colon on the left side. So we want to make sure that we're looking lateral to the colon, looking for any fluid that is in that area. It is very common for females especially to have fluid in their posterior and anterior cul-de-sacs. The posterior cul-de-sac varies depending on patients who still have uteruses. So males and females who have had hysterectomies, their posterior cul-de-sac is going to sit in between the rectum and the urinary bladder. Females who still have a uterus, the posterior cul-de-sac then is the area between the uterus and the rectum. And this is going to also be known as the pouch of Douglas or the rectouterine pouch. So here we have fluid in the posterior cul-de-sac. This is the uterus. Fluid in the posterior cul-de-sac, and this is the rectum behind it. We can also have fluid in the anterior cul-de-sac, which is going to be on the other side of the uterus. And this is called the vesicouterine pouch, as it sits in between the bladder and the uterus in females that still have their uteruses. So once the uterus is gone, the anterior cul-de-sac and the posterior cul-de-sac kind of meld together, and that is just all going to be called the posterior cul-de-sac then. Fluid in this area is very, very common. When a female patient ovulates, the release of the egg from the Graafian follicle also releases fluid along with it. So what we call this is physiological fluid. What we are more concerned about is if we see a lot of fluid in the pelvis within either of these cul-de-sacs, or if we see very complex fluid that might represent some sort of internal bleeding. We mentioned earlier about making sure that we identify where the diaphragm is and then identify what side of the diaphragm the fluid is seen on. In this example here, we can see the diaphragm right through here. This is the diaphragm. We have the liver right up against it, so there's no fluid on the inferior portion of the diaphragm. We are, however, seeing fluid in the pleural cavity here. When you see fluid in the pleural cavity, you're going to see typically anechoic fluid, maybe some loculations within it, and then you'll see what we call a consolidated lung. The lung is collapsed upon itself, usually kind of flapping around as the patient is breathing. But again, this is going to be fluid superior to the diaphragm in the pleural cavity. I've got another example here of a pleural effusion and actually ascites as well. So here we have the diaphragm dividing the two cavities. This is that consolidated lung kind of flapping around with a pleural effusion around it. And then inferior to the diaphragm, we also have ascites. Mentioned earlier that it's going to be important for the sonographer to be able to delineate between a subcapsular fluid collection versus a peritoneal fluid collection. So these two pictures are from the same patient. The patient had some sort of trauma to the abdomen, causing a subcapsular bleed in the liver. So in this picture on the left here, we have a CT. This is all liver, and then we can see this bleed also in the liver. What we're looking for is a subcapsular, meaning that it's below the Glissen's capsule. You can kind of see this echogenic band all the way around. That's Glissen's capsule. That means that it is subcapsular within the capsule of the organ. The spleen also has a capsule around it, so that is another organ that we want to assess. Is it within the capsule or is it outside of the capsule? Kidneys as well also have capsules around them. You can get a subcapsular hematoma in the kidney, or you can get one outside of it. This is the ultrasound image from this patient. All of this fluid around here is new blood, so a very large new hematoma. This patient definitely is going to need some sort of intervention. But the key part about subcapsular hematomas or subcapsular fluid is that typically, even though that fluid is there, the fluid and the organ still kind of take on the same shape. So nothing has really changed about the borders of the liver. It is just now filled in with fluid within the capsule. We also mentioned earlier that we want to be able to distinguish retroperitoneal masses from intraperitoneal masses. So when we see something in the retroperitoneum, what we typically see is that it is going to push those peritoneal organs, push those peritoneal vessels a little bit more anterior. And that is what we're seeing in this CT as well. So we have this retroperitoneal mass. We can see that it's kind of shifting everything out of the way from in the peritoneum and actually some other retroperitoneal organs. So we have the aorta here, we have the renal vein coming over to the IVC here, and we can see that this mass is just kind of pushing everything out of the way more anteriorly on the patient. Contrary to that then, if something was in the peritoneum, we would see things kind of get squished back the other way. Switching back to some more normal anatomy of the retroperitoneal space, remember we talked about the adrenal glands, diaphragmatic crux, and the para-aortic lymph nodes. So first, beginning with the adrenal glands really aren't seen well on adults. They kind of disappear into the fat that surrounds the kidneys and the spleen or the liver. So this is not a bad view of the adrenal gland. We actually can see it pretty well, better than we can see on most patients. So this is an adult adrenal gland, but compare that then to the pediatric adrenal gland. We can best visualize adrenal glands in the prenatal phase. So still in utero, we can see them actually pretty well. We can also see them in neonates and for quite a while into early pediatric care. On this example here, we can see that the cortex is the outer edge here. The cortex is the hypoechoic area, where the medulla, which is the middle, is the more hyperechoic area. The diaphragmatic crura are also visible by ultrasound. Remember, there is a right one and a left one, and they are going to be best viewed when we are in the longitudinal plane to the diaphragmatic crux, which also happens to be just longitudinal on the body. Looking at the right crus, it runs posterior to the IVC, the liver, and the right kidney. So here we have a picture of the liver, and we can see this hypoechoic line traveling towards the diaphragm behind the liver. So this is the right diaphragmatic crus. We can also see another image here. We have the IVC. This is that IVC portion here. Looks like we have maybe the gallbladder here, liver, and the right renal artery. We can again see a dark hypoechoic line traveling posterior to the IVC, representing the right diaphragmatic crus. Switching over to the left side, looking at the left crus, it does also travel posterior to the spleen, and it's going to kind of rise up and travel in between the left lobe of the liver and the aorta. I really like to point out this structure because a lot of new students will see the crus and be confused about what's aortic wall versus what's not, or might think something is wrong with it. So the diaphragmatic crus runs in between the liver and the aorta, and it runs right along the aorta wall, quite often kind of distorting the appearance of the wall in this area. Hypoechoic area labeled number 2 is the left diaphragmatic crus. We can see in this image it's labeled, again, it's that hypoechoic linear structure just anterior to the proximal aorta. We already talked about the esophageal junction. We can see that even more superior to the crus right before the aorta pierces the diaphragm. Wrapping up our ultrasound images then, we'll take a quick look at the abdominal wall with ultrasound. Now oftentimes this is really what our abdominal wall looks like. We're using our curved linear transducer to image the abdominal viscera. And so it's just kind of in the anterior portion of our picture, and it's always going to be there. The sound has to travel through the skin, the subcutaneous fat, all the muscle layers, through the fascia, and then into the peritoneum and retroperitoneum where our organs are hanging out. So abdominal wall, almost always in our pictures. However, we can optimize to look at the abdominal wall a little bit closer. So in this image, we've switched to a linear transducer, so we've got much higher frequency, and we're taking a closer look at the structures that make up the abdominal wall. First thing that is going to be visible is the skin, and then right underneath it we will see a layer of fat or adipose tissue. The next superficial layer of muscle is the external oblique muscles, then the internal oblique muscles, and lastly the transverse abdominis muscles. Notice how they each have kind of a brighter fascia in between. These are the epineuroses of the muscles that come together to form the rectus sheath. And then we can see the fascia transversalis underneath that last layer of muscle. This is going to be the last facial plane right before we get into the peritoneum. So beyond this last bright fascial plane is the peritoneum or the abdominal cavity. And in this example, we can see small bowel right underneath it. This image also shows us those muscles. So looking on the lateral side of the abdominal wall, we can see the external, internal, and then the transversalis muscles. Up on top here, we can see the rectus abdominal muscles. And then through the middle is the linea alba. Another thing that we can see in this CT picture are the posterior muscles. So we have the psoas muscles sitting on either side of the vertebral body. And then underneath it, we have the quadratus lumborum muscles. So the psoas muscles are a little bit more medial. The quadratus lumborum muscles are a little bit more lateral. So looking at the quadratus lumborum muscles, this is an inferior left kidney, and we are seeing just a little bit of that quadratus lumborum muscle, a little bit more lateral and posterior to the kidney. The psoas muscle is very easily recognizable by ultrasound. We can see it running medial and posterior to the kidney. So in this long image of this kidney here, we're in the medial portion. We're getting more towards the hilum of the kidney. And what we can see is this striated hypoechoic structure posterior to it. So this is the psoas muscle. Now if we turn transverse on the psoas muscle and start sweeping down the psoas muscle towards the patient's hip, where it's going to connect into the femur, we'll get a picture more like this. And as we are coming down the abdomen towards the hip, the iliopsoas muscle or the psoas muscle ends up being kind of this rounded hypoechoic structure with shorter fibers running through it. Now this is going to serve as an excellent landmark when you're looking for the appendix. We can actually see a normal appendix kind of draping across it and then continuing to drape across the external iliac artery and vein. However, this psoas muscle can sometimes look very suspicious for a retroperitoneal mass. It can look kind of like intussusception to a new scanner. So you really want to make sure anytime you see something questionable, always turn on it. If you get something elongated out like this with a bunch of fibers running in that direction, it's most likely that psoas muscle. So make sure that you're always looking at any questionable structures in two planes. To finish up this lecture then, just a brief discussion about some of the protocols that go along with the peritoneal cavity, retroperitoneal cavity, and the abdominal wall. Starting with the peritoneal cavity, a dedicated peritoneum ultrasound may be ordered to evaluate for ascites. Remember, ascites is the fluid that's found within the peritoneal cavity. So for this type of exam, the sonographer is going to want to use a curved linear transducer. You're going to want to have the patient supine and start them out being rather flat. If you're kind of seeing a bunch of fluid in a bunch of different areas, you're going to take long and trans pictures of it, going through all of the quadrants, right upper, right lower, and left lower. And then when it comes time to actually drain this fluid, we might want to sit the patient up just a little bit so we can get that fluid to kind of move into the dependent portion of the body, which typically is the pelvis. So quite often when we are scanning and have a decent amount of ascites, we are going to see bowel loops floating in an anechoic fluid. So this is all bowel with that ascites surrounding it. If there is enough fluid and the patient can handle it, then a paracentesis will be performed to drain that fluid from the abdomen cavity. Looking at a dedicated retroperitoneal ultrasound, those can be ordered, but typically if a retroperitoneal ultrasound is ordered, then it's going to be modified to indicate the area of interest, because remember we have the kidneys and the aorta and the IVC and the adrenal glands, all sorts of organs hanging out in the retroperitoneum. So typically it'll be a retroperitoneal study for kidneys or it'll be a retroperitoneal study for the great vessels, including the aorta and the IVC. Again, these protocols will be discussed a little bit more in detail in their respective units. However, we do tend to see these structures whenever we are performing a complete abdominal ultrasound. We are always evaluating everything that we can see in our pictures, and that quite often is going to include the aorta and the IVC and the kidneys within our abdominal imaging. Dedicated abdominal wall ultrasounds then are warranted, especially to evaluate for maybe a hernia like we're seeing here in this image. We can see this moving area here. There is a defect within the abdominal wall musculature or in that transverse fascia, which is allowing that small bowel to course through a small hole and up into the musculature. So that is a hernia that we are seeing here, but we can also do dedicated abdominal wall ultrasounds to take a look for soft tissue masses, such as lipomas, which are little fatty nodules that can form in the adipose layer of the tissue, or we can look for hematomas, which are basically bruises within the skin or within the muscle. When we are interested in just the abdominal wall layers, looking at the muscles and looking at the fascia, we typically want to use a linear transducer so we can get more detailed images. Another interesting use of ultrasound regarding the abdominal wall is to guide a needle during a nerve block procedure. So if a patient is not healthy enough for general anesthesia, or maybe they don't even need full anesthesia, they can also use these nerve blocks as post-surgery for pain control, and it's also been used to help patients that have broken ribs. They end up doing a nerve block so they can't feel the pain from those broken ribs every time they breathe. So what ends up happening is that a needle is guided using ultrasound into the abdominal wall. A numbing medication is injected directly along the fascial plane. That usually is going to interact with nerves through that area as well, and that's going to alleviate any sensation within the abdominal wall for the patient. So in this picture here, we can see that they're coming kind of from a posterior lateral approach. We are going through the skin, the adipose layer, and then we can see our 3 layers of muscles. We are a little bit more towards the back here, so we have the spinal vertebrae in this image here, the aorta just anterior to it. So we have our psoas muscle and our quadratus lumborum muscle. So we can see all of these structures in our ultrasound image as well. Again, we have our quadratus lumborum muscle, the psoas major muscle, we have the vertebral body down here. And what we are looking at is that fascial plane that divides the muscles from the peritoneum. And so this is where that fluid is going to be injected, so it can kind of numb this whole area and help with pain control or provide anesthesia for some sort of procedure. And that brings us to the end of our Unit 7 lecture. Make sure that you are going back through the workbook. Look for anything that has been bolded or preceded by one of those arrows. Those are going to be very important pieces of information. Also go through the activities that are in your workbook and the open-ended nerd check questions to check your recall on the information provided.